Okie dokie. Thank you for coming back so quickly. We'll make a start with the last two workshops of the day, and we will endeavor to finish before the scheduled end time. So this is workshop number 3, symptom control, dealing with psychological distress. And if I can just get the next slide, there we go. So we have two presenters, Dr. Melanie, Dr. Bassam. So Dr. Melanie is a New Zealand health psychologist who's worked in Dubai for many, many years. She's trained in the psychology of health, disease, and treatment processes. She has a postgrad qualification in psychology, pharmacology, and rehabilitation. Doctoral research was in the psychoneuroimmunology of breast cancer, and she helps to run psychosocial support groups for cancer patients, has past university teaching experience as well as publications in many leading international journals. Thank you very much for joining. And Dr. Bassam's, introduce everybody in one go. So Dr. Bassam Dahia is a dedicated psychiatrist originally from Iraq, but been practicing in Dubai since 2019, building on years of experience in the UAE. Now works for Valence Clinic, and expertise covers diverse psychiatric conditions across many cultural backgrounds. With a robust background from the University of Baghdad, he earned his bachelor's in medicine and surgery in 2007, and Dr. Dahia is skilled in managing psychiatric emergencies and severe disorders, integrating traditional and holistic approaches into tailored treatment plans. He's a core faculty member in Dubai Psychiatry Training Program and mentors future psychiatrists, collaborates with institutions like DHA, and advocates for mental health awareness through many different social media channels. So a special thank you for Dr. Bassam for stepping in at the last minute as well. Dr. Tariq, who was due to present, I think he had to go back home. Family illness, his mum was not well. So the floor is yours. Thank you.
Okay, it's lovely to be here. Thank you so much for the introduction. Talking about psychological distress today, and I believe we've got about 45 minutes. It may actually be a bit shorter today because I realise so many people in presentations, there's such an open discussion about psychology and the impact of how psychological factors affect people when they're undergoing difficult times, when they're unwell, when they're going through the oncology and palliative care context. So I think it's so important to talk about distress because it intersects so much with our work as psychologists. And what I want to do today is really look at how we view distress from a psychological perspective and show you what we need to look out for, because obviously the goal is enhancing quality of life and reducing suffering wherever we can. If we do have any time, once I've talked about distress and the cases, I could talk briefly about measurement tools. I believe that's going to be covered a little bit, and also the psychological interventions that we use. But I'm strongly of the belief that if you can really connect with your patients and have a dialogue, have a discussion with them, you're actually halfway there. If you can really find out what's going on for them, what's on their mind, that is a lot of the therapy right there and then. And I think Dr. Katie mentioned before as well about having open communication and having the compassionate care, which is obviously the goal when people are struggling at a very difficult time. So just to say very quickly, what is distress in oncology? As you can see here, it's a multifactorial unpleasant experience. We have the psychological, social, spiritual and physical nature, of distress that interferes with the ability to cope effectively with cancer, and the symptoms and the treatment. What we know is a lot of the time if we're called to the floor, people will say to us, oh, quickly, they're in pain, something's going on. And we know it's not necessarily just about pain. There could be a whole lot of other things going on that we need to consider. And so that's what I want to emphasise today, is that distress is multifactorial. It's never just one thing that's going on. I know the total pain model has been discussed today, and as psychologists, if we look at the key distress indicators, it looks pretty straightforward. We've got the physical, psychological, social, existential and spiritual concerns. And just to cover very briefly, again, I know this has been covered today, but if we look at physical symptoms, pain is obviously one of the biggest ones, the biggest reasons that we get called in, because what we need to know is it's obviously not just the physical pain that someone's going through that's distressing, but it's the meaning that patients attach to it, because we know obviously they will, they'll interpret any kind of increased pain as perhaps disease progression. So it's actually finding out from our patients, how are they perceiving what is going on for them? What does it mean to them? If a physician comes along and says, it's okay, we can give you something, what does that mean to the patient? Are they saying, okay, well, you're going to reduce the pain, but what does that mean in terms of my disease? Thank you. And fatigue is another one. And this isn't just about someone feeling tired. This is about a profound, a persistent exhaustion that doesn't really improve with rest. So you have to look at how is that going to affect somebody's quality of life, how it contributes to making them feel very, very helpless and hopeless, especially in a hospital setting. And we're also, with the physical symptoms, always looking for anything that appears to be uncontrolled or unpredictable, symptoms like nausea, breathlessness, inability to eat or move independently, anything that indicates a level of distress for us. These psychological factors as well. The biggest things that we see are the fear, anxiety, and depression. So fear, all of the time people will say to you that they're worried about pain, they're worried about death, they're worried about recurrence. Anxiety, that's always showing up as a persistent worry. So worry about the prognosis, what's going on with their body, what's going on with their families, and the anxiety is ongoing, it's persistent. Dr. Bassam's going to be talking a lot more in depth about this, but again, it's just looking for what are your patients saying that they're worried about. In terms of depression, also extremely common. What are people saying to you about their sadness? Are they interested in having any visitors come to see them? How are they reacting to you when you come into the room? So we're looking out for the behavioural signs and also, again, what they are telling you. In terms of social factors, obviously, it's very, very clear that cancer doesn't just affect the individual. It's impacted their entire social world. So we'll see a lot of people feeling very helpless again because there are role changes. I had a patient not so long ago who came into the hospital. She'd had cancer in the past. She came in for a routine blood test, and they basically said to her, with her certain numbers that she had, you can't leave the hospital. So immediately everything was thrown into disarray. She was working, she was a mother, she was a wife. So we have to think about how people are affected significantly when they're coming through the doors of the hospital or the clinics. And again, how are they being affected by their physical situation? Also, we'll see a lot of people who are socially isolated as well. So they may be diagnosed with very, very serious disease and they don't have that kind of support system. So again, trying to find out for them, who is in your world, who is supporting you? Financial worries also are often categorised under the social category. Obviously a major source of distress, especially if people don't have insurance. So the cost of treatment, potential loss of income, concerns about providing for the family. These are often things that people don't talk about. We often feel it's not really our place to say, what are your financial circumstances? How are you? But again, if you connect with your patients and you find out really what's going on for them, that information will inevitably come out. Lastly, the existential concerns. People, again, they will tell you if you have that relationship with them. They will say, why is this happening to me? What does it mean? What do I mean? If you're nearing the end of life, they'll say, what has my life been about? They're trying desperately to get some kind of a model to everything that they know about themselves, what they believe to be true about life, and what lies ahead for them. There's also anticipatory grief, mourning for the life that they'd planned, and obviously a future that they may not see. In terms of spiritual distress, this is a big one, people wrestling with their faith. wrestling with their belief in a higher power, loss of faith, or even intense search for spiritual meaning. So for people who are maybe not necessarily religious, but wondering again, how can I put a model to this? What do I believe to be true about what's happening to me? So as you can see, obviously if people come in, even if they're just coming in, not just, but if you're told, okay, this person's experiencing pain, please could you go and see them? It's not about just that physical pain, although you would assess that, but what you're looking at is how that fear might be amplifying pain, how it could be disrupting their social connections, and obviously how it might be challenging their sense of control, their sense of meaning. Obviously, as psychologists, our role is to help identify the various manifestations of distress and understand how they all interact together. And it's already been pointed out today, but it really underscores the need for the kind of multidisciplinary care that we need, collaboration with everybody on the team to really know who is our patient, at what level are they suffering. Cultural considerations, I believe this is going to be covered a little bit today, but just again, making sure that you know exactly who it is that you're dealing with. What are their perceptions about what has happened to them? Is this a test from God? Is this something that they have to get through? Is this because they're being punished? Is it because they were unhealthy in the past? Knowing someone's illness perceptions can tell you a lot about how they then behave and what coping strategies they utilise. We also look at the role of family, the community support, how active they are in reaching out for support, communication of diagnosis and prognosis, expressions of pain, how people believe they should express pain. Do we say I'm in pain? How do I say that I'm in pain? If you're a busy physician and you're coming to see me, maybe I'm too shy to let you know. I see that you're in a rush. I'm not going to tell you everything about what I'm going through. So again, as psychologists, we have the time to really talk to our patients about what they're going through and try to extract what's going on for them. It's also important to know about any kind of spiritual or religious influences and taking account of any gender or modesty concerns that they have. So just to sum up, sort of common end-of-life distress factors, the biggest ones would be the fear of pain and suffering. So many people will say to you, I'm scared, I don't know what's next. What happens? Again, they need some kind of a model to understand, what they're going through, to have a sense of control. And the concern for family well-being is often very high too. And likewise, the concern of the family for the patient will increase too. So you have to be prepared to engage a lot more with the family and explain what is going on and help be a moderator at times. There's that existential and spiritual distress. The loss of independence and dignity is a big one. We'll cover that in the case study. And unresolved personal matters. This is a big one when people will start talking about particular family conflicts or conflicts with, say, business partners or extended family. Maybe they're seeking forgiveness in their relationships. The problem is that they know their time is limited, so there's an urgency to these kind of questions that they have. And the main thing as well is that, we know obviously distress intensifies and it fluctuates. We know the focus is often shifting from that curative treatment. It's going to the provision of comfort, and that can be very disabling for people because maybe no longer they're seeing the oncology team. They're not seeing those people anymore. They've been moved on to somewhere else. So they're losing that connection with the team that they knew. We've got to think about what does that mean to them? Does that mean there's nothing more that can be done? Does that mean they're going to be forgotten about? Again, it's very important because we know that this can create a lot of the anxiety and the depression that you see. So people really need to have a sense of control about what is happening to them. They need to know that they're feeling cared for and that they're being listened to. So I thought I'd just start off with a quick case. This is going to show you again how this model is multidimensional. We have 54-year-old Western male, actually sounds like one, Western female, sounds like one of the cases actually from before. She was a marketing executive, stage 4 diagnosis, recently divorced, 2 teenage children, depression and mood swings during past treatments. And in this particular case, she had pain, fatigue, weakness, lymphedema, shortness of breath. Again, these are things that have been talked about today, and emotional distress. So she had a lot of anxiety. She has that history of depression there, the history of mood swings, the fear of worse suffering. So this is someone who'd already been through cancer, already been through all of the treatments, hadn't been too long, in a period of remission, and then had been diagnosed again. So it was just like, oh, how much more can I take? So a lot of big fear there of the suffering, losing independence. Socially, we think about this as a marketing executive. Now, she's not going to be able to continue what she loves to do. It's going to be a lot more difficult given these various factors. So challenges in maintaining that identity, changing dynamics with her friends. They didn't know what to say anymore. A lot of people felt exhausted, actually. They'd helped her for several years going through all of these treatments, and then she'd got to a point she was diagnosed again. It was very difficult for her. She said, people are not reacting how I need them to react. There were concerns about obviously being a burden, navigating then co-parenting with her ex-husband. They had been divorced for a reason, but she was having to strike up some kind of a better relationship with him because of the children again. So a lot of factors coming into play there. Existentially questioning her purpose. There's a lot of struggle there, grief. You see the grief there over the future plans, everything that she'd hoped and dreamed for. An interesting one that comes up as well is regret over prioritising career over personal life. So that's something to think about. And desire to leave a lasting impact, but not sure how she could. Oh, did that go? Oh, sorry, I just didn't catch that on the end. And the spiritual distress, trying to seek some kind of meaning in her experience. So I thought it would be interesting to talk about the psychological support in palliative care if we think about it, all those different dimensions. If we start off, if I should get this right, with the physical considerations, given what we know about this person, what do you think would be important? Even if I'm not a physician, but what would be important to think about in terms of the pain that she's going through, or everything that we've just mentioned now? What do you think sort of physically would be important? You think? So if you remember, it was, that's going to be a bit fast there. So she had a lot of pain. There's that fatigue, lymphedema, shortness of breath. And there's the situation there.
Yeah.
So physically.
Yeah, so to control the pain, not only the pain, she has the pain and she has the lymphedema, which is also causing her distress and pain. So we need to control the pain, symptomatically control her shortness of breath and the lymphedema. All
Right.
of them, the 3 of them. This is physical only. I'm
Yes.
talking about the physical aspect.
Yes, and then thinking from the psychological perspective, and I help it along a little bit, like helping her also communicate
Yes.
effectively to you about what she's going through and how that feels for her. A lot of the time, as I said before, people don't know how to talk about their pain. They'll tend to say that they're fine. They'll do a lot of minimising when actually they're very scared. So these are things that you need to extract from the conversations. Addressing her fears about even pain management and advanced disease. And then there are quality of life decisions too, so supporting her in making decisions about treatments that balance quality of life with longevity. So what is she going to do with her pain management? Would she take a medication that would make her perhaps very, very drowsy but would take away the pain, or does she want to be more alert so she could spend time with the family but maybe having to put up with a bit more pain? So having these kind of conversations, Does she want to undertake any further chemotherapy? Does she have it in her? Maybe the whole family are saying to her, yep, you need to have this. You will be fighting. You are actually doing something if you're having treatment. We need to try and help her find out, what is important for her, what can she actually do. I've had a number of patients that I've come across who have said, actually, I don't have the fight in me. I've been through too much. How do I say to my family, I can't do it anymore? So the kind of conversations that need to be had, and things like feeding tubes, ventilation, resuscitation preferences, again, that wouldn't be done directly by me, but it would be helping to support them in, are you doing something that you feel comfortable with? Are you agreeing to things that feel right to you? So helping communicate wishes effectively is very important. In terms of the psychological and emotional, if you think about things that are going on for her, with all that information, what do you think would be important to help her with? All of these kind of things. So this is often underestimated, the kind of work that we do, helping people with the diagnosis. They may have been diagnosed. Again, what does it mean to them? How do we help them come to terms with it? Helping her through that grief process, supporting the children as well. That's something that's very important. You see, so we're taking aspects of this distress model and we're breaking it up. That would be very important. The children start coming in more because they're worried about, obviously, their mother, but they need to be seen as well. And emotional regulation, obviously strategies for managing anxiety, depression, fear, helping her cope with all of that uncertainty, maintaining hope, finding balance between, as morbid as it sounds, preparing for death and living fully in the present. So any small goals are very important. If people just want to eat a little bit of food without feeling sick, if that's important to them, that's where we start. If it's having a particular conversation, that's where we would start as well. So we try to work out what is important for them, and we work in levels. Socially, helping her navigate those changing dynamics, getting used to grappling with the friends who are maybe not so available anymore, or the ones that are not so forthcoming, having those difficult conversations, and assisting again in the unfinished business and personal relationships. So she in particular had a number of things that she needed to do, but again, when we think about social factors, this can really put people at ease. It can reduce a lot of stress and anxiety when they feel like they've got a bit of a clean slate. Maybe they've forgiven people, they've had particular conversations that they need to have, and again, it goes a lot back to that sense of control. Existential concerns. We've got ideas of what we might tackle.
We're waiting for this because we have no answer for the existential, especially
okay, right,
this.
okay.
Yes.
Just for this particular case, helping her redefining her sense of self outside of career and also physically. That's a big one. That's a tough one, and supporting her in maintaining aspects of herself as a mother as well, because now she's feeling, I know she said at the time, just feeling completely incompetent and useless, just saying I don't really fit anywhere now, and it's all because my body's failing me. So how do I make sense of that? How is this fair? So it, really labouring through very, very difficult psychological challenges, and assisting her in identifying ways to leave a lasting impact for her children. So because she'd been so busy all of these years with her career, she suddenly thought, my goodness, how can I make something for them? So this is when things like dignity therapy come into play and are extremely valuable in sort of mapping out a person's life and having something to leave for the children as well. And again, helping her address any regrets and finding closure. And end-of-life planning, and we often have social workers as well, but people, often it's physicians who will go in and talk about, have you made a will? Have you got, passwords and keys and whatnot stored here and there? Because the problem is we know that things can change so rapidly. Even if you're working with someone who's been given 3 months or 6 months or 12 months, things happen very fast, and so people need to be prepared, and someone needs to be able to have those conversations. So that's partially some of what we can do as well, and we try to do it in such a gentle way that it's not raising levels of stress and anxiety, but there are some very necessary conversations that need to be had so that you can prepare a person and prepare their family as well. And spiritually, looking at questions about meaning and purpose, and in this case, helping her find sources of hope that align with her reality. So we focus on acceptance and commitment therapy is a good one for this. Accepting, we say sort of acceptance, being open to basically difficult and unhelpful thoughts and feelings in a very, very difficult reality, but acceptance and commitment therapy, but committing to the life that you can, despite all of these worries and these difficulties going on. So we really focus in on that very present moment, having meaningful moments and bringing a lot of life into whatever she can do in that hour or that morning or that afternoon or that day, really, really breaking it down. Sometimes I feel like it's insulting people's intelligence when you say we just need to help you to be calm right now, and let's just look at one thing that we could do today that would be really meaningful for you. But when you break it down, by the end of the week or 2 weeks or 1 month, you've got a whole pile of things that are very meaningful for a person. I had a second case, trying not to do mass generalisations here. Again, this also seems like a case that was similar to one of the ones presented before, but just showing you differences again. So I think the main thing, if you take away anything from this presentation, is how distress, it seems like, physical, social, psychological, it seems like we're ticking boxes, but no, you can see there's a really real complex interplay of factors here. So there was an Arab Muslim male here. He was the owner of a company, again diagnosed with metastases, limited time to live. He was married, he had grandchildren, and his physical distress, he had a number of things there causing physical distress. Emotionally, he had a lot of anxiety about losing control of his business. He was the one who kind of ruled the roost, and he had all of the control, and suddenly he wasn't going to have much of that control anymore. So that was very, very distressing to him. He was very frustrated with all of these physical limitations. Feeling dependent was terrible. I was like, no, I don't want them touching me. I don't want anyone doing this for me. I don't want this. You'll hear it a lot in the hospital as well. People fight, they don't want diapers. They don't want feeding tubes, things like this. They're doing anything just to keep up the very, very simple things. So he was also very, very scared of being seen as weak. And this is a person he was in one of the rooms that we have, which have a kind of an entrance, and it was almost like a little mini cafe that his family had set up where all the guests were coming through and they were being offered tea and food and everything, which is as per custom. This was totally normal, but for him it was just so much. It was like, how do all these people are seeing me in a bed. This is diabolical, this is terrible, and this is what I have to do. So there was so much distress there, and obviously there were already some mood changes there due to what he was going through. Socially, again, you see the overlap here, the tension between wanting privacy and then the expectations of what his family wanted. His family was so happy to have everybody coming from all over the place, all over the region to come and visit. They felt supported, they felt great. He felt terrible about it. There was also the family were having very, very big reactions to how he was. And he had a big concern about family conflict starting, and it was all over inheritance and who was getting what. And he was also a little bit uncomfortable with female healthcare providers. Existentially, would see a number of things here. And the fear of being forgotten or family moving on too quickly. His belief was, as he was losing control, he thought, my business is going to go to whoever, and I'm not going to have a say in that. He worried about dying very, very quickly and just thinking that people would just grab the money and run and that he'd be forgotten. So he was struggling, thinking, you know, what's my legacy going to be? He also had some interest in seeking forgiveness and resolving some conflicts. And spiritually, very, very strong believer, but questioning why God had given him this trial. He said, this is too tough. This is too tough. I know that we're tested. I've been tested throughout my whole life, he'd say. But this is now not fair. So what's going on? Had concerns about not being able to complete Hajj because he was obviously physically unwell. He wanted to recite the Quran, but he'd often get breathless. He'd run out of energy, and he felt very bad about that because his whole life he'd always recited out loud. Now he felt that if he did it in his mind, that it just wasn't quite the same. That actually gave him significant anxiety. And he had some struggle between being told, there's really nothing more that we can do for you, and then, you know, the family saying we must pursue treatments for you, and putting him through that. And he had some anxiety about judgment in the afterlife. Had he done something maybe wrong in his life, that he would be judged. So just to go through quickly, we're thinking of all of these things that are extracted from this model of distress. Again, physically. Now this is a ton of things, I won't read them out, but as you can see, the simplest things, oh, okay, they're in pain, but let's really think about what that means. Anxiety, depression, sleep, concentration, irritability, and it goes on. All of these symptoms that he had all relate to something and end up as something psychological. That loss of control. Remember, the loss of control is a really, really big one. We have to find as quickly as possible what is meaningful for someone, what calms them, what puts them at ease so that they feel that they can get through those hours or those days, helping people in terms of the frustration that they feel, in terms of their limitations, so trying to set some goals. Again, getting some control, getting some independence. He had self-image concerns, so we explored those fears about feeling very weak around people. There was an anticipatory grief, family dynamics, because of the changing relationships and also the cultural factors. So again, there's so much there that you need to take into account. Socially, so we had to really look at that. How much privacy do you need? Do you think you could see this many people in the afternoon? Is the afternoon the best time for you, or is the morning the best time? You know, always sort of working in so that trying to get everybody to be happy in his particular situation. How to cope with the relatives. He thought that they should all come and see me so that he could be left alone. I mean, this kind of thing. His worries about potential conflicts. So trying to help him actually get some people on board that he really trusted and loved, that he felt he would be comfortable to give some of his business to and start making some decisions for him. And obviously there's that cultural sensitivity, addressing discomfort with the female healthcare providers. Even me, I was very, very cautious. We had a number of people on board who could speak Arabic and who had similar beliefs, things that he would feel very much at home. You want someone to feel very comfortable, that a person actually understands everything that they're thinking, that they're going through, and obviously helping him with shifts. And existentially, and we would do this for everybody, you know, meaning-making, legacy work, reconciling with people, the afterlife anxiety, again, constantly looking at these bigger picture things where we can help people. And in this case, the spiritual considerations there. Balancing psychological support with the desire for religious leader involvement too. That's something that should be offered as well, having people come in from the outside He had various people coming in. They were reciting with him, they were talking to him. He felt very, very comforted by that. So again, we certainly can't do it all. Even as our teams, we have to really think about, what would this person benefit from? And obviously facilitating any kind of spiritual practices within physical limitations for him. So as you can see, it's just really picking up on everything that's important to him and trying to set little goals around that. So does that give you a little bit of an idea about maybe how we would deal with distress, how the different aspects of distress? If everyone's tired, bored.
No, it's nice. Again, the last question. How do you answer the patient when they ask you, why me? Still, we don't have an answer for that. We try to support them, but do you have a better approach for this? I know we don't have an answer, but an approach, how do you approach it when you have a patient who's asking, why me?
It's continually asking a question of the question, why are you thinking, why me? And we talk about like the downward arrow technique. We just say, well, what does it say or mean about you? If it is you, if you have been chosen, if this is from God, what would that mean to you? And so you keep exploring. We always say, what does that say about you? What does it say about the situation? You just sort of keep on going. So actually we address it by trying to get more information to even they're trying to work out, what does it mean? So as you know, there's no fixed answer. And it's a tough one because you feel so helpless when someone says that because of course you desperately wish for that not to be the case for them, but it's helping them getting out as much information so that they start thinking, because as I say, if they go back to that place of feeling a sense of control with what they understand to be true about the situation, that's very helpful in reducing that stress. It's okay. Okay, maybe we should hop on to, yep. I think that's you there.
Hello? This one. Oh. Hello? Hi. So good afternoon. First, thanks Dr. Neil for the beautiful introduction. And thank you, Dr. Melanie, for the presentation. I think you took a big part of mine, so thank you. You made it easier. So, first about the agenda and objectives. Basically, we're trying to find strategies, identify, assess, and treat psychological symptoms in patients. With serious illnesses, focus on evidence-based approach. It's not just the anxiety, depression, or the existential distress. It's all together. The mind and the body is not separate. It's all connected, and that's why we need the holistic approach. And as we see, by definition for palliative care on the WHO, it's approach that improves the quality of life of patients, their families also, who are facing problems associated with life-threatening illnesses, prevents and relieves suffering through early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. And thank you for mentioning that. Because as a human, when we talk about a holistic health, it's not just our physical or mental. Big part is considered about our social life, includes our spiritual needs. We need all that connection to feel healthy. Of course, it differs from one person to another. So, what's the psychological distress is very common, of course, common for the patients and their families. But for the patients, we found out that 50% of patients report some anxiety, depression during their course of illness, if not mix of both. Also, anxiety mainly comes from the fear of death, pain, what I'm gonna do next, what I'm gonna do about my work, how I'm gonna take care of my family, and so on. So, depression, mostly about having those things. I'm involved in that. I cannot take care of my family. I cannot take care of myself. Suffering from the pain. So if the patient comes fluctuating between both. There's also the existential distress involves of fear of meaninglessness or hopelessness, or the main question, as the doctor asked, why me? What does this mean? Of course, uncontrolled distress can affect the quality of life, adherence to medications, and even survival. We'll talk about that soon. First, most of those patients, with every stage, they're going through some grieving in one way or another because they lost something in their life. They lost their social life, they're losing their, let's say, physical strength. They're losing their eating habits. They're losing their communication, not the same home, not the same comfort. And always there is some stages for grieving. Like, I'm in denial, I'm not going through this. There's anger, why me? Why not someone else? I didn't do something wrong. The bargaining part about for example, if I pray more, this will go away. If I be good to my cousin who I haven't spoken to for 20 years, this will go away, and so on. I'm not talking about realistic bargaining. Then, when that doesn't work, there's the depression, and then the acceptance. But it's not a natural flow. It's not like one step after the other. It's not linear. There's no time frame. Some people get stuck in one stage, like depression, like anger or denial, and can be influenced by new information. Like they were going through depression, but then a new medicine came. They involved like a new treatment. And there's like, oh, bargaining again, and so on. So it can fluctuate. We need to pay attention to that. Of course, what to tell them? Like not to do that? No, because every treatment, every management differs from one person to another. We just listen to them and see how it goes. We help them find the solution. We help them go through these stages on their own, but we are there to guide. Of course, that part you're more involved in, more than me. So, but why we're thinking about depression, like when the patient is facing a life-threatening illness or condition, how will that affect their treatment? Because if it's left untreated, patient can be associated with increased physical symptoms, suicidal thoughts, worsening quality of life, and emotional distress. More impairs the interaction of patient and their family, which is during a pivotal time in which the patient need to say goodbye, thank you, or planning death, or even the communication to help them get better. And that's what we hope to. Depression symptoms can affect the patient autonomy, which in return make them feel more depressed. So you go through that cycle. So it's like, okay, I don't care. Do whatever. Give me whatever medicine. But also feeling they're not involved in their treatment will make them feel more depressed, more dependent. And lots of patients get depressed by just that. as you mentioned, like lots of patients avoid using diapers because they lost a part of their autonomy. They don't want that. So I'll go through these publications and honestly some writing skills to save time. I know we're at the end of the second day. We don't want to take too long. I prefer to save that time for discussions and questions. So basically, this study was conducted by asking caregivers, and they found 46.4% of patients has some moderate to severe anxiety. And it worsened during the last week of life. But they also noticed that they were significantly associated with caregivers' burden score and inversely associated with patients' age. Because think of it this way, with patient age, their social life, their activity, their physical strength, and so maybe already deteriorating. With someone younger going through that, they feel a big contrast. So they're more anxious, more depressed. Of course, I'm not generalizing. It's just a theory about it. So, how we screen, how we check. Before reading the slide, lots of patients find it easier to complain about physical symptoms than mental symptoms. I'm not saying I'm depressed or anxious because it feels like a weakness. No, I can handle this, but it's easier to complain about pain. It's easier to complain about nausea, headache. But is it really there or not? Yes, it can be really there, but at the same time, having depression or anxiety can worsen it, can worsen these symptoms. So, simply, we can go through questionnaires like rating skills like PHQ-9, GAD-7, or HADS. They're always available. I have them here on the slides, but I'll go through them fast. It's essential to differentiate between grief and sadness and depression. Yes, they're right, they are humans. Of course, you'll feel sad, you're losing something, part of your life, part of your health. That's natural. Of course, you'll feel anxious because you don't know what's next. But is it anxiety? Is it depression that's crippling your judgment, affecting your health? That's the part that we need to assess. And that's what the part that rating skills help with, because it will show us how severe it is. And I want to say that's always essential to check for delirium. We all know delirium, but sometimes it gets confused, especially with the hypoactive delirium, because they're not troubling for the staff or for the doctors. A patient is just sick in his bed, not talking. So it's fine. They're receiving their treatment. But no, they are going through delirium. I'll explain that later. And also, if the anxiety or depression is caused by their medical condition or by the medications that were given. We need to know about that. It's a long list. I'm just giving examples here. Like having cardiac issues can cause depression. As 50% after a stroke, people do have depression. Endocrine, hyper or hypothyroidism, neurological conditions, respiratory conditions like asthma, or anything that cause difficulty in breathing can be perceived like a panic attack or anxiety. So, gastrointestinal, irritable bowel syndrome, for example, there's 80% of it related to anxiety. Which one causes the other? It's fine. But at the end, it's serotonin receptors, 10% in the brain, 90% in the gut. So that's why when we feel, we get butterflies. And the chronic illnesses. But also the medications for these illnesses. Like, consider any stimulant can cause a panic attack. Asthma medications, can affect. Hormonal, like corticosteroids. Corticosteroids can be even used for side effects of chemotherapy. But at the same time, corticosteroids can affect the receptors in our brain, causing insomnia, agitation, and some people have some hypomanic symptoms. They become talkative, over-energetic, and so. Once they stop the corticosteroids, it decreases. So we need to balance. Blood pressure medications. Lots of people complain of depression in their mood. I'm not saying depression, but depression in their mood, because it decreases the energy. It's not they're used to high blood pressure, they're over energetic, but then the blood pressure back to normal. So relatively it's lower. So they feel tired. They feel not focusing as before. They don't have that rush as before. So it's relatively felt as depression. And of course, the chemotherapy, which is known to everyone, how it can affect the mood. So these are the rating scales. You can find them online. I'm not going through them fast, to be honest. It's just like go from 0 to 3, and then it shows the severity. Same, that's for depression, this is for anxiety, and the HADS. But let's talk a bit about delirium. What is delirium? Think of you're just waking up, and for that moment, you don't know where you are. You don't know what's happening. Just for a small moment. That patient is living in that moment. So, maybe during that moment, he recognizes a face, he recognizes a place, but it keeps fluctuating. And that's why when we need to check, it's always about the orientation. The default is time, place, and person, but it's not once. 1, 2, and 3. So it's acute disorientation, altered levels of consciousness, disorganized thinking, inattention. You have the symptoms. But why I focused about the hypoactive? First is more common. They're withdrawn, they're drowsy, which can be perceived as they're depressed. They're not talking. It's harder to detect because they're not causing trouble. So they're avoided. Although it means they're more physically ill than the hyperactive. And you'll notice that someone with hypoactive delirium gradually improving in health physically, they can shift to hyperactive and then the delirium goes away. And that's the reason why it has higher risk of mortality. The hyperactive, after a couple of hours, we get called by our staff because they disturbed everyone around them. Some people with delirium, they have automated replies. So when you check, like, how are you doing? I'm fine. How are you? How is everything? I'm fine. They have just automated, especially with elderly. They know like this, the etiquettes in conversation. But if we ask more complex questions, you'll notice there's a defect there, especially about time and place, more than the people. Because if that comes in waves, they have gaps, so they don't know what happened, so they lose the track of time. The same thing about the place where if they were moved to a different room or not, if they're at home or in a hospital. This, a long list of what can cause delirium. Of course, I'm not gonna read all that, but you can see it can be caused by anything, especially in elderly. And can you guess what's let's say 2 common causes of delirium? Can you give me examples?
Sepsis, UTI, urine retention.
You're right. There are 2 we always forget about. Constipation and pain. For elderly, they can cause delirium. Yeah. So, okay, before going there, We always need to check about pain, hydration, nutrition, environment, because if they're in the same environment, there is no window, they cannot tell the time, morning, night, or so. And of course, input-output for food and for fluids. Mobility, medications, and we need to check about their vision and hearing. Some people used to use glasses or hearing aids, but when they're in the hospital, it's not with them. So they're not hearing well, they're not seeing well. That can make them more confused. So there's a small list. It's called delirium, which is basically goes through everything I mentioned, plus the impaired cognition, and plus the sleep part. Because with delirium, they're mostly up during the night and sleepy during the day. We mentioned all that. For the medications, with delirium, we try to avoid benzos. They calm the patient at that moment, but it makes them more confused. So you're just covering the problem. And it's like you're making it worse. So sometimes less medications is more helpful. Of course, it's all about treating the cause. We focus on the non-pharmacological treatment, which I'll come to next. And of course, the early mobility and everything we mentioned about the glasses, hearing aids, and so on. So that's a test was available on NHS. Do you see can you find the 10 differences between the two images? But I'll make it easy. Find 6. Because to be honest, 4 of them are very hard to find.
You found something? The eyeglasses, watch.
Yes.
The window is open in one of the picture.
Yes.
There is something in the comedian I cannot see from here.
Where? Right side or left?
In the right.
Here?
Yeah.
Okay. That's a cane.
And looks like the collecting bag in the bed.
Here, this one.
This is X or?
Yeah. You mentioned the main ones.
Yeah, I mentioned.
Okay. So
Yeah.
I'll show you them. Okay. So first, because some of them are not shown in the picture well. The medication box, it was between full and empty. That's number 1. So they're taking or not. Number 2 is the AT4 assessment, which is very, very simple. Basically, if they're, it's about the attention, about acute changes, and so. They just kept it next to the bed, and here it was just a paper. The third one, the glass is full and it's empty, so they need to drink water. There was a hearing aid also next to the glasses, which doesn't appear well. The watch, you're right, and the bag. The cane is for mobility. The earlier the mobility, the better. And of course, number 9, although it's not showing well here, the calendar that's followed, and the window. We always need to put like a window, a clock, and we keep orienting the patients every now and then, even if they don't know. It helps a lot. Plus, helping them feel involved. So, now done with the delirium, let's go back for the psychological distress. What pharmacological management we need to give? The default usually goes with SSRIs, like most tested and generally the safest. Few years back, there was Brintellix, which is an antidepressant considered SSRI, but it's more multimodal, and it was approved for elderly before 80 and for cancer patients. which is good because of much less interaction with other medications. With SSRIs, I'm always careful about one thing, if they're taking aspirin, because it affects the coagulation, okay? But always it's a balance between benefit and risk. For acute anxiety, if they're not going through delirium, we can use benzos. And not just benzos, I'll mention other examples like gabapentin or so. And of course, with such patients, we don't have to worry about addiction. We need these days for them to be better, to be more comfortable, and for their families also. So, but not always benzos, not always all the time. If there was some agitation, especially there was a risk of delirium, we go to antipsychotics. Why? They slow down that brain activity. So they make them sleepy as a side effect. They make them less aggressive, less moving around, less agitation, so it's better for them, and sleeping better. At the same time, I think the most commonly used is quetiapine. We need to keep in mind quetiapine can cause hypotension. So if it's causing that, we need to modify their antihypertensive. And if they're going through chemotherapy, having hypotension already, we need to be careful with that, not to go through it. And of course, we need to go the lowest dose and then see the effect. We want to make more benefit than harm, of course. With this one, it's a publication about how it helped. The help, like the improvement and their responses. So I don't need to go through it. It's just explanation for what we already know. There was, okay, the factors that should be considered in antidepressants in cancer patients. If there is post-psychiatric history, if there's like their concurrent medications, somatic symptoms, if there's a double benefit, as we mentioned, from quetiapine, for example, decreased blood pressure and sedation, and their comorbidities. So, but what about the augmentation? We always, when we face a bit like a closed door, we need to open other doors. So, psychostimulants, like the ones used for ADHD. Other augmentations I mentioned on the side, or esketamine. Well, let's start with the second one. It's fast somatic relief, but risk of delirium should be kept in mind, as we mentioned. Quetiapine is the default one. I think olanzapine is the second. Benzos can be useful if it's just anxiety and for sleep. Pregabalin, gabapentin can be mixed also for both the anxiety and for the pain. And as I mentioned, addiction is not a concern in this case. What about the stimulants? They can help momentarily. Same as benzos, they calm the patient directly. Stimulants can give the energy. But we need to be careful about increasing in anxiety, increase in blood pressure. Because the idea is they give dopamine, a reward center. They increase it, so I have more motive, I have more attention, I am enjoying things more. It's not externally, not internally. Esketamine or ketamine, I don't know if you're using ketamine here, but for us, because there's the esketamine spray. Okay, so great. So it can help with the pain plus the mood effect. But we need to be careful about the dissociation with the delirium and the increased blood pressure. Otherwise, it's generally safe with the low dose. Now the non-pharmacological interventions. Thanks, Dr. Milani, for covering that part. Yeah. So basically, the default is CBT, but also mindfulness techniques, breathing exercises, and so. I'll not go through them more because we already had a big part described perfectly by you. But what about the effect? They saw with depression, there was a large effect with CBT and psychotherapy. With anxiety, it was less. Because anxiety, it's natural. We're naturally anxious, we naturally worry. It gives us motive in life. If I'm not worried about an exam, I'll not prepare to it, and so on. So there's a natural part. And they have a cause to worry about. They have their reasons. Yes, it will relieve, it will decrease that level, but still there will be some anxiety. And they noticed that the frequent the session, the better, but the longer the session didn't help much. That's like the summary of this study. And we come for addressing existential distress. It needs a unique approach. Basically, meaning-centered therapy helps patients rediscover their purpose, even as even as they approach end of life. We listen actively, we narrate, we help them find the solution, to be honest, as Dr. Melanie said. Because honestly, I thought of a question at the end of your presentation. We're dealing here with, we always talk about Maslow's hierarchy of needs. Starts with the basic needs, basic needs, then safety, then social, and then the self-esteem and the self-actualization. We reach this level in life. With those patients, every stage is getting broken. Their physical needs, they're independent. They're depending on others. The second part is safety. How will they feel safe when they're facing death? Well, how about the safety of their loved ones? Their social interaction is affected. Then we come to the main things, self-esteem and self-actualization. That's what they're holding to with the existential part. So there was a preparation for a role play, but I'll skip that, not now. And it's about interdisciplinary collaboration. That's why it's not just a psychiatrist or psychologist that should handle that. It's the whole team. If one member of the team informs the patient that it's fine, start this medicine and you'll get better, that can be false hope. Yes, it gave temporary relief, but then it ruined the whole report. Like how can I trust you again if you told me I'm improving? We need to be careful with that. So the social workers, chaplains, psychiatrists, psychologists, and other specialties, they need to work together. Simple as that. Yes, and the time finished, so any questions, suggestions, please let me know. Sorry? There was a thing about guided imagery on your slide. This one? Which one? Tell me. Sorry. No worry. No worry, no worry. Oh, sorry, I turned it off, yeah. So, please, anything? Please.
Thank you. Thank you very much, very comprehensive. So I have a question about palliative care and therapy in terms of, how long do you think, because we don't often have a long time in terms of a therapeutic window. Exactly. So we reach for the drugs for our patients before we think about referring for therapy. Yeah. So obviously the results are good, from what you're saying, depression, anxiety, they improve with therapy. Yeah. But But what would you say would be, I know this is a real huge generalization, a minimum number of sessions that a patient might need?
Honestly, it differs from one to another. Plus, it's, as you mentioned, it's kind of a condensed course. It's not just like, come next week and so on and so on, because changes happen within a day. So these changes can happen to the medications and to the therapy, both of them.
So are we saying it's still worth referring for support?
Yeah, that's why there was one slide I skipped through. They saw that the referral percentage is only 27%. So we do need to increase that.
Thank
and
you.
of course, the screening to be done first, so we know, prioritize which case, like which one is more severe and which one is like can be handled.
My question is rather similar about timeframes. In terms of starting antidepressants, I was always taught and understood that there's no real benefit in starting antidepressants unless you have at least months prognosis, because you're not going to see a therapeutic effect for at least a month. But anecdotally, I often see a response before that, whether that's placebo because the patient knows they're taking an antidepressant, or true chemical effect, I don't know. So I was interested to know what you think about timing in starting an antidepressant, and perhaps if time is much shorter than a month, what else you might recommend we could use just to lift someone's mood.
First, choosing the right antidepressant should be very important. So for someone who's more anxious, we need to choose an antidepressant with more calming nature. And for someone who's depressed, more activating and more motivating. The activating ones can work a bit earlier than the calming, but still, both can work. First week, honestly, I'm not expecting an effect. I usually call it side effects week, because we're just observing how the body of the patient responding to them. And we always need to go slow, which means we need to go for a longer period. But that's when the augmentation needed, like the 3 choices that we mentioned. These 3 choices usually put last in other patients, but in palliative care, no, should be considered from the beginning, because we need to push the effect of the antidepressant, then the effect of the main medicine continues, catches on and continues. So for someone anxious, yes, we need benzos, but at the same time, we need to be careful about respiratory rate, about confusion. There are few choices that don't affect the respiratory rate, but still, not everyone. And one benzo didn't work, that doesn't mean the other doesn't. So even though it's the same family, the same thing with SSRIs. Something doesn't work, that doesn't mean the others won't. So I think that's the main thing. I always start with the lowest, at least for, let's say, 2 or 4 weeks, depends on their tolerance, depends on their medical conditions and their profile. And then consider increasing to the therapeutic dose as soon as possible without causing an increase and disturbance in their mood or side effects. Meanwhile, we're using the augmentation.
Thank you. Interesting workshop. Thank you for that. I have a question or comment. Regarding the psychosocial support for any patients with terminal disease, I see that you treat the patients as an isolated islet, that without a community. We have a real scenario that a patient suffering from such problem and he needs the psychosocial support, but he's in the middle of a community conflict or a state conflict. And this is actually, he lacks a lot of things. How we can deal with such condition? Another question that is a patient, the source of his depression and psychological distress is his family or his community. And you said that the family and community is very important to support him. So do you think that it's better to isolate him from the family? Thank you.
Thank you so much. Great question. Honestly, I faced lots of cases with anxiety or depression just because of their isolation when I was working with COVID patients. Like they're totally fine, but then when their social support system that they're used to changed, they found themselves alone in a room, they freaked out. They couldn't handle that. So yes, it's a big important part. What we do in that case, because I know they're staying there for maybe a short period, so I can manage with medications during that period. And if, like, for example, a case I know they're staying for 2 weeks, why to start an antidepressant that starts working after 2 weeks? No, just give them something to calm them down during this stay, and then they'll go back to their social life, everything back to normal. But at the same time, as you mentioned, some of them, the source of their anxiety is outside. So we need to be careful. That's where the social workers and chaplains part come handy. They're like a buffer between the stressor and the patient. And of course, we have to be in control of that. So it's a whole work. We cannot just tell them to leave the patient. We cannot just tell them to stay with him. We need to balance that. Because we're always face some stressors. But with these stressors, if we find that it can be managed, that will be more relieving to the patient than just avoiding them. That's personal opinion, to be honest. So, Dr. Melanie, do you have any comment about that? Oh, okay.
There's just one, maybe everybody online is sleepy after lunch.
They had with us.
So Sundari is asking, again, very, very broad questions from the online community. What is the role of the qualified psychiatric nurses who have training in palliative care? I mean, I would just simplify the question.
I would say that's
perhaps
more important than my role. Because
Yeah.
they're the ones dealing with the patient all the time. So handling any small distress can stop it from getting bigger and bigger. Yeah.
Yeah.
Yes, please.
So we have trouble introducing yourself as palliative care to family.
Okay.
But there's more trouble even introducing psychiatry to family than palliative care. It's even worse than death, I feel. Okay.
Exactly, yeah.
And I work with kids, but with adults was similar here, especially. People are not used to mental health psychiatry. I'm from Saudi Arabia with Wajdan. So we really believe in it, and we believe in the work of our psychiatrists, but together to come in the room, if we don't get approval from the parents, a big thing. So we try to sugarcoat it. It will help with sleep, will help with, he's going to be adherent to his treatments, try to sell things. So my first question, so how do you want us to sell you so you can come and at least pitch, what you can do for the patient, so you can at least get there. And the second question is we deal a lot with teenager or older kids, and they're a long time in the hospital, not necessarily end of life, but leukemia patient, long hospitalization, and they often shut down completely. They become very irritable, they hide themselves, they start not adhering to treatment, pulling their tube, So they're very, very tricky because it's also affecting actually their potential for survival, These are curative case.
Thank you so much. Honestly, I faced the other side where it was cases were referred to me and I come to the room and say what are you doing here? So, and when I ask the patients don't you have any problem I can help you with or so, and they just deny it, no, I don't need a psychiatrist, simple as that. So yes, first, when they complain about something, I cannot sleep, I cannot, I'm having this pain, explain to them that, maybe there's a doctor we refer to help you with that part. They are the expert in that. It's not as a psychiatrist, it's not the mental part, it's just because they know the medication, the interactions and so, and they're part of our team. So that can be accepted easier. Plus, as we mentioned, it's easier to complain about physical thing than mental thing. Gradually, you'll see they open up on the other side. For teenagers, and sometimes even with elderly, they react more than mentioning, I'm sad, I'm anxious. No, I get angry, I get frustrated, I refuse to eat, I even go to the toilet or so on. So it's part of, I'm kind of still in control of something, although I'm not. Plus the temper changes, because when you're anxious, when you're depressed, it's like you're a full cup. Any drop makes you overflow. So we see that on the roads when we're driving. Some people cannot tolerate a honk. You see them like shouting, moving their, so that's the same idea, because honestly, my approach with such people is like, are you okay? And it's like, they didn't expect that, because they expect like you're fighting with them. So when you ask that, it's like, oh. So the same thing with teenagers. Are you okay? Not. Why not? Let them speak, let them vent out. Okay? And then gradually to involve the specialist in that. Okay.
No, it's okay. So I think what we'll do, given that it's oh, sorry, round of applause, Dr. Melanie, Dr. Bassam, sorry. So what we'll do is, this is the last session of the day, and well done to everybody who's lasted this far. Oh, see. I'm not going to stand on stage because this is not my comfortable area. Okay, this is the last workshop of the day, and this is the workshop that generally gets people talking and people are more interactive for, because there are no straightforward answers. So are you presenting first? Or is it me?
It's not me.
Okay, let's just see. Who's presenting first? Is mine? Okay, all right. Am I too far? Have I broken it? What? Oh, sorry. I did have one comment about antidepressants in palliative care. We are getting patients referred to palliative care at an earlier stage, which means I am more likely to give somebody an antidepressant than I would as if they were referred at a later stage. Increasingly, especially when people are really struggling to come to terms with the fact that they have an advanced cancer, particularly when these people are not talking, they're not allowed to speak up. The family have taken a lot of the decision-making ability away from them. When their mood is so low, you can't actually assess their physical symptoms very well. So increasingly, we see a lot of patients who are very, very irritable. And unless you do something for that irritability, which is a reflection of their low mood, you can't actually assess their pain. So I would say, always choose your patients well. Make sure things like the sodium is okay, because all the antidepressants drop the sodium. But be brave as well. We have a gentleman on the ward under the care of the oncologist, really miserable pain. He gave Dr. Rasha a really, really hard time, 719. I mean, God, such a prickly character, and palliative care teams are really quite thick-skinned, but my God, this man was difficult to deal with. 2.5, 3 weeks later, the mirtazapine kicked in. And he's still miserable, and this is his right, but at least he's interacting with us, and he's able to tell us his pain is better. We can see. He's going out of the room now. He's going out once a day in a wheelchair. It's not perfect, but little bits. Everything is small, baby steps, baby steps. So be brave with the antidepressants. Don't wait too late. Okay, so this is there's 3 slides, really, really quick. This is just one example. There are hundreds to choose from. It's okay. So this was a 16-year-old local patient who was diagnosed with a low spinal cord tumor. She was treated extensively in the US. I think it was MD Anderson. Unfortunately, despite that treatment, her tumor spread to the brain and the leptomeninges, the lining that wraps around the brain and the spinal cord. So the plan was to get her back home to the UAE, which they did, and she was admitted under the care of our medical oncology team. Oh, what? My Tula? Oh, the music. So we were seeing this girl for a number of weeks. So we saw her daily on our rounds. And at the family's request, they said, actually, we want you to take over her care. They said, we like the oncologists, but they don't listen to her. They don't talk with her. They talk at her. So this is not a criticism. This is what we are good at, generally in palliative care. We are able to spend a little bit more time with the patient. So we took over her care. And she was well supported by the family. There was always a family member in attendance, either a brother, cousin, her parents were great. And so we looked after her for quite a number of weeks. Symptomatically, things were reasonably well controlled. She had headache, she had back pain, as you'd expect with her disease location. But they responded to standard medicines. We didn't have to use anything fancy. But then the problems started to happen, and we discussed these with her family at multiple stages. So if you have tumor affecting the lining of the brain and the spinal cord, typically what starts happening is you start picking off your cranial nerves. The nerves at the top end of the brainstem. So the paralysis progressed. She had cranial nerve deficits. She was unable to vocalize. And then she started hypoventilating, resulting in becoming a bit hypoxic and hypercapnic. So she was getting drowsier. GCS, conscious level, was going down, as we'd expect. And we had many, many weeks of conversation with this girl and her family. She herself was very open to talking about her symptoms, her headache, pain, but nothing beyond that. The dynamic was very clear. This is what I'll talk about. Anything else, speak to my brothers. And the brothers were great. They let her speak, and we spoke in the room, and anything very, very sensitive, we spoke outside. That was the family dynamic, no problems. We spent a lot of time speaking with the brother to say, look, all of these problems that we've mentioned will happen at some point, and now they have started to happen. What is going to happen next is that she will end up needing ventilatory support very, very soon, unless we decide to take another path. Now, the family were a very lovely family to deal with, fully aligned with palliative care. They were a joy to deal with. They said, look, Doc, we understand what you're saying. We like your team. What you've explained is very clear. We respect it. But we are not ready to let her go. And I said, I know, and I can't know what it is you're feeling, but if I put myself in your shoes, I would probably say the same thing. And this went on back and forth. There was no decision-making being requested. It was just, we kept the lines of communication open. But they insisted on life-prolonging treatment. They rationalized this by saying, we know that making her live longer by putting her on a ventilator will make her suffer more. But we believe, these are their words, suffering is part of life. We all suffer. And we know that putting her on a ventilator will make her suffer more. But we also believe that the more she suffers in this life, the more blessings she will receive in heaven. There was nothing I could do to change their mind. Nothing. And she deteriorated as we predicted and as the family expected. And this required an emergency intubation and ventilation. She then had 48 hours on the ventilator in ICU, and then she died. Arrested, had one cycle of CPR, and then she died. And the family were completely fine with this. I was more irritated. In fact, I was very irritated. Because, we'd spent 6 weeks thereabouts with this family who were kind of like the model palliative care family. They were really, really a joy to deal with. But I'd never been put in this position before. And I've looked after patients of all faiths for many, many years. I've never had this sort of rationalization. So we published this. Anonymized, etc. But because it's such a bizarre thing. So, has anybody experienced anything like this? Yeah, and we spoke about that. So I don't know how people deal with this. How do you make sense of this?
Yeah, as a PICU physician, we see this a lot. And I think, especially in this part of the world, it's a huge source of distress for us as physicians and nurses and RTs and social work in the ICU. Sometimes it's because the discussions haven't happened before they come to ICU, and sometimes the discussions have happened. But there is this belief that differs perhaps from our own, and we struggle with providing medical treatment that we consider completely futile or potentially inappropriate based on our medical expertise. And so we're put into this position of doing things that we perhaps consider to be harmful to our patients, which depending upon what your code of ethics are, you might really, really struggle. And sometimes, when there's opportunities to have a longer discussion with families, I do mention the Hippocratic Oath, and this is the reason that people are having difficulty with your choices, because from a medical aspect, we know this. However, I think when people talk about it from a religious or spiritual aspect, they don't quite see it the same way we do in the biomedical model.
Agreed. You're going to say something?
I wish if our colleagues from Saudi Arabia were still here,
Yes.
we would have heard from them about their experience, because from religious aspect, especially Muslim belief, we believe that whoever, or some people have this belief that struggling here will give you more rewards and will guarantee you a better place in heaven. So I wish if they were here, at least we will hear from them, and how do they deal with the AND and DNR. Yeah, it's different.
But Kim is here, so Kim can give us the Saudi perspective.
You can tell us, yes, please.
Okay.
Yes.
Can I?
Yeah.
Are you happy to comment? Thank you.
Hello, everybody. Yes, we have this belief, but not like it's presented here. Like if you had a situation and you did not choose to be in this situation, you will be receiving like ajr in heaven, but not intentionally putting myself in this. You know, it's different how they mention it here. Thank you.
And my understanding as a non-Muslim and a non-religious person is that actually Islam is actually very clear on intentionally causing suffering.
No, it's not intentionally. Yeah, this is different.
No, this is what I mean. But Islam is very clear on relieving suffering. Is my point.
It's the opposite. Totally the opposite.
Yeah. No one.
Sorry. I totally agree with her. It's not causing suffer that is going to reward you in heaven. It's just to be patient, because this is, according to our beliefs, came from the God. It's not from anyone here in the life. So you have to be patient with that. Whenever you have patience, you will feel relaxed. You will feel you don't have a problem. You will not get anxious, and you will reward at the end. But they are not intentionally to cause suffering for the patients. Just be patient. Not.
So let me just ask for clarity. In us doing this and putting her on a ventilator and subjecting her to a prolonged life in such a debilitated state with no chance of recovery, is this viewed as increasing her suffering?
Culture-wise, whenever you are a physician or there is a scientific opinion that patients need this, we are going to accept as the family. And although there is some suffers, we have to be patient, because we know that this is, according to cultures, the God is doing like that.
Right, okay.
Okay, thank you.
So,
Sorry, no
a question about that, because what does God want you to do? And is it the person who is actually going through that suffering who is making that decision, or a different family member who is not going to really experience that pain? I was talking to one of our Saudi Arabian colleagues over lunch about this, so we talked about the fatwas that are there about the DNA CPR, but what he did say was that there hasn't been a fatwa issued about palliative care services. So he was giving examples of when families have got offended by the palliative care team being open about the prognosis of patients, and when they have been barred from visiting the patient's room for a week just before they died. So, yeah.
I think Dr. Mohammed was going to say something.
I join what have been said by my colleagues. In Islam, we have rewards when we support, when we are patient face situations that we didn't choose. But I think when families give this kind of reflections, there's a misconception about the idea. But I think deeper, simply they are in denial phase. They don't want to stop, as if they are abandoning their children or parent. This is the real reason, not the blessings, that the reward. But they put this as a justification. Even so, we want the CPR, we want everything. Maybe he will just to justify.
It's easier in a way. So this was the background to the case. So this patient, as per the...
Excuse me, just I wanted to add the one thing I forgot. About the fatwa that you are talking, in Saudi Arabia we have this common scenario, and there are strong and solid fatwas about that if a medical act or procedure is going to be suffering for the patient, it's legally haram to do it. So even when we say this to our patients, then they will accept. We don't face this in Saudi Arabia, honestly. I think this is cultural here. They want everything. It's not religiously.
Correct. Okay.
Thanks, Katie. Is that on? So I'm going to be devil's advocate for a couple of things. One is, do you think she actually suffered? Was she aware enough to suffer, if we're talking about her suffering? And the second bit is we talk about palliative care being care for the patient and their loved ones. So they're the ones being left. No, I'm saying this from a point of view of I feel this is wrong. But with experience, what I'm learning is there are many ways of doing the same thing out there. So is it wrong for the family to go away feeling they did everything? Because they're the one left with the memory. And if she was 86 rather than 16, would the family have chosen something else? I have no answers, it's just...
Yeah. And these are valid questions. So this young girl, and again, I should have done this in more detail. We were never put in the position or allowed to be in the position where we could ask her what she wanted. That simply wasn't the dynamic. I broached this discussion with the brother and the mother and the cousins, because they were all party to this, and they're like, well, no, this is what she wanted. She told us, do everything to keep me alive. So in the absence of anything else, it felt inappropriate not to respect their wishes, which is why this happened. The reason we gave this case as the background is because, as per the UAE allow natural death law, she meets the criteria for allow natural death, meaning legally we are allowed to institute a do not resuscitate status. The Arabic version, it's interesting, you look at the official translated versions, they leave out one line at the bottom of the English version, which says that you do not need the family's permission to make this call. That's in the Arabic version, but it's not in any of the official English translations, even online. So I had to look it up. Somebody, a colleague in DOH, sent it to me, and it's very clearly there in the Arabic version. So, we could have avoided this, but we didn't. One, because this is what the family is saying the patient wanted. But as you say, how many of us have been put in this position where we are forced to do something that we feel is inappropriate because we think it is going to make that person suffer, but because there isn't that robust clarity and a medical legal framework to protect the doctors, we just go down the path of least resistance. Comments?
Aside from the complexities of the family asking for this because of religious reasons, I've had quite a few instances, mainly in this country, but also in the UK, where physicians have told me that actually ventilating a patient in respiratory failure is a more pleasant way to die than to allow people to die of respiratory distress off a ventilator. And so have advocated ventilating patients when they know there's no reversible cause for their respiratory failure, so that they can die in peace and not be distressed. So I was just wanting to add that as a fact. I mean, hopefully she was extremely peaceful and relatively unaware of what was going on, but I'm interested to know what people feel about ventilation being a palliative measure at the end of life.
And again, with this patient, her GCS was already quite low. She was very, very calm, and we had very clear conversations. And I said, actually, this is the body doing what it does. The body, you could view it as the body is preparing for death. She's very, very peaceful. She's very, very calm. She's not aware. She doesn't appear to be suffering or in any distress. But as soon as we start doing things, I know it's going to cause some harm and some discomfort. And they very fairly said, well, actually, if her conscious level is so low, what difference does it make? She won't feel anything. And that's a fair point. It's not right or wrong, but I understand that rationale. They're not doctors, we are. So anybody want to comment on either that point or Katie's point?
Hello. The 2016, the law which is prevalent for the UAE, if you look at point 5 and 6, they are contradictory, because point 5 says that if 3 medical professionals agree, you don't need the family's, the patient's consent. Then the point 6 says that if the patient asks for resuscitation to be given, then you have to give it. But it doesn't mention about family members. So this is something that we have asked our external legal to clarify, because all our allowed natural death forms are based on this. The second part I wanted to kind of open out to the floor is we think about the family's distress. It is paramount, the patient's wishes. But what about the physicians and the treating teams, emotional distress as well? And in the UK, if you are not agreeable, and going back to the Hippocrates Oath, if your first principle is do no harm, and you at the bottom of your heart feel that you are doing harm in this situation, what are the provisions available in the UAE to bow out of providing care and to get a second opinion? Has anybody dealt with that?
I mean, I can say we have dealt with it, and there are no provisions explicitly stated. Kim has a question. Just to say, DOH earlier this year, late last year, put together a group of people to put together a ethics rule book. It includes all of these things that we are discussing and the lack of a framework. DOH's position was that they didn't want to be too prescriptive. I said, no, for something like this, you have to be prescriptive. You have to be absolutely crystal clear, because, and again, last week I was in ICU at one of the other hospitals, and this patient was clearly dying, walked into hospital, deteriorated, became profoundly septic, maximum multiple vasopressors, widespread disseminated malignancy. There's no way, multi-organ failure, she's not going to recover from this. And the oncologist refused to sign the DNAR form because he says, well, we satisfy all the criteria except the fact that she's treatment naive, so I haven't given her chemotherapy. I said, I understand that, but her biological state is such that she will never be well enough for chemotherapy. So I don't criticize him, but again, we can pick holes in the current policy depending on your perspective. Kim, you were going to make a comment.
Just it's more like a question, maybe I'll even throw it to a critical care physician. I think sometimes I find it sad as a palliative care, we should not embrace there's one type of death, that we need to die peacefully at home with your loved one. I mean, this is not the goal. There's different type of death. There's people that will willingly want to die on clinical trial, even if they're sick like dogs, because they're thinking, I'm helping science. There are people that go to war as a soldier. They know they will die badly, and this is their choice. This is their dignity. Right now in that situation, maybe she was not really feeling, she's sedated, she's already, but maybe you prevented the suffering of this whole family that was not able to come to terms with this in such a short time that you had. And a lot of kids, actually most kids are dying in the ICU. And I think we're doing a study right now, it's like almost more than 3/4 are dying in the ICU. And personally, sometimes when I look at these kids, I'm happy they're in the ICU because they're getting the care they need that they would not necessarily get on the floor with the particular burden of symptom they have and the requirement of equipment. So I don't know if my colleague from ICU has...
yeah, no, I think this is one of those things where we have a particular vision of our own, perhaps, of what dying with dignity is, what's a good death. And as much as, you know, I might feel a certain way, I think it's really important to understand where the family's coming from. You go back to Cecily Saunders in terms of, you know, the words we use and the experiences at the end of life. We may carry many, many deaths in our years of service and our clinical exposure, but what is left with the family has to fit what they're most comfortable with. Yep. Even if we don't want to be the ones having to do CPR for that last 10, 15 minutes, and we would have rather have the child been held. We have a debrief afterwards, which goes back to the comments from you in terms of how do we as a team manage the emotional burden that we carry and the distress that we experience from providing care we perhaps don't agree with. In that particular aspect, we do have to detach and recognize that we are simply tools that are being used to provide a treatment that the family wants, whether it's going to succeed or not. And I do struggle with it, but I also appreciate that, you know, at the end of the day, it's not my life, it's not my death, it's not my child.
That's true. I agree with all of that. We struggle with it every time we have a patient who's on the palliative care ward, and we've had very good relationship, but the kind of elephant in the room is that they're still full code. We don't seem to be able to get away from this yet, but increasingly I've made my peace with it. Because you can't fix all the problems. And for some people, this is okay. It's acceptable. I have, on a number of occasions, and I don't know whether this is right or wrong or inappropriate, but maybe slightly arrogant. I don't think it's arrogant, but I've said to them, I said, look, you have given so much back to us. You've given us all your faith and all your trust. Your communication with our team has been really, really good. I want that to continue over the last few hours or days of life. And I have to say, I really am uncomfortable doing this for X, Y, and Z reasons, because I think that my Western training and Western ethics framework, which for all intents and purposes is what we follow here, it's just not documented as such, says that my duty of care is to the person in the bed. So with the greatest of respect, I really disagree with this, but if this is what you want for your family, we will do it. But if things go wrong or you get upset about certain things, I'm sorry to say you need to be aware this could all have been avoided if we allowed the more comfortable path. I don't know whether that's wrong to say, but I've had no kickback from the families, and they've all said, thank you very much.
I think that's a great approach, actually.
It's just weird, but it just felt like the right thing to do.
I think it's being open and honest.
I think, Neil, I take a similar approach to you, having perhaps come into the UAE all guns blazing, thinking I could just lift my UK model into the UAE. I feel like I've done the job well, and I feel satisfied with my own input. If I have explained that there's an alternative to going to ICU, if they know that it doesn't have to be that way, that they don't have to be resuscitated, that they might suffer through interventions and we've had a decent open conversation about it. If they still choose that they want full active treatment, then I feel at peace with that myself.
And I think that's correct. And just as counterpoint, when I was a trainee, I was in my final year as a palliative care trainee before I had my consultant post, and this was at Imperial, and there was a very difficult case, hugely traumatic case. We had this massive Schwartz round twice because there was so much distress about it. A 25-year-old Russian lady with a really nasty, aggressive rectal cancer, and metastasized, and maybe 2.5 weeks into her admission, she had a horrendous stroke, massive bilateral MCA stroke. So she'd gone from being angry and awake and alert and communicative to being aphasic, GCS 7, 8 most of the time. And okay, it was actually quite easy to care for her one-on-one in terms of staff to the patient. What was incredibly difficult was dealing with the husband. You know, and you know, he actually wasn't Russian, he was Ukrainian. And you know, for me, I had to speak to my consultant on a daily basis because I felt so out of my depth. Nothing I did worked. You know, he'd argue with me, he'd shout at me, he'd swear at me, but he would never turn me away. I just kept going back every day, just very gently erosion, bit by bit, bit by bit. And some days I'd just sit in a room with him. He actually allowed me to sit with him. And he didn't shout, he didn't kick me out of the room or threaten to hit me. And then, you know, the week that she was dying, you know, he said, people don't realize this is not what you expect for life. You know, we're 25, we have 2 young kids, both under 5. My life is ahead of me. She's not just my wife, she's my best friend. So, you know, my life is gone. And this is a wealthy, successful guy. He's got all the resources in the world. But for him, he was just inconsolable. And he had this thing, he explained it to me that this was a particularly Ukrainian trait. So he says, you guys don't understand about Ukrainians. You know, you cut off my legs, I'll keep hobbling. You cut off my hands, I'll try to bite you. So, you know, there's always something else to try. So, you know, when we face these issues, this is not a uniquely UAE experience. This happens everywhere in the world. So it's, when we get these situations, I do reflect and I think, well, actually, I have dealt with this before. But it's hard every time it happens. So this is effectively a kind of a debrief. So have we done this one to death, I think? Pardon the pun, no. We did.
So I just wanted to add one comment, just in my experience, and maybe the health literacy is a little bit different in UAE than it is in Qatar, but a lot of people don't understand what resuscitation is and what DNR or DNAR means, and that's not just lay people, that is healthcare providers. And misinformation by healthcare providers to families has sweeping consequences where they become quite steadfast in their position. No, you will do everything for my child because someone has told them that DNR means pneumonia. No, we don't give antibiotics, we don't give oxygen because you signed a DNR. And that becomes really difficult when things actually really do progress because they have this perception that they won't get this pain and symptom management that they actually really, really want. So if there's opportunities to educate people, I think we should take every chance we have.
Agreed, yeah, fully agree. Cool. Anything else? Yeah.
And maybe one day a position statement from the US about DNAR, because I think the understanding is very poor in the community.
Yeah, I think we should not rewrite it, perhaps rephrase it for them. Yeah. We have one more. Oh, Rita, please.
I did try to stay quiet. Just a comment, not a question. Everything you've said touches all of us to the bone, but it goes back to what we've been saying right from the beginning. Palliative care and end-of-life care doesn't start at the end. It starts at the beginning. A personalised, person-centred plan of care is really, really important right from the beginning. And to talk about these sensitive issues that might take weeks, might take months, might take years. But once you start those conversations and involve the whole of the multidisciplinary team, then you're going to get understanding. And I know it's difficult, but unless we start having those conversations and making that multidisciplinary, person-centered plan of care, including sexual intimacy, for example, nobody's talked about that so far. Sexual intimacy at the end of life, advanced directives at the end of life, comfort care, do not resuscitate. These are all things that it's really, really difficult, and as Dr. Katie said, we need education and training, and that needs to be now. Thank you.
And I think we can get very far down the rabbit hole, and it's very emotive. And people have very strong feelings one way or the other. But we are in a very, very young country. How many years was medicine practiced in the UK before we had these structures and guidelines in place? Many, many years. So the difference is now, you know, the UAE, because of its resources, has brought all of us here, which is why we're here. We are doing what we love, and we have the opportunity to do it differently. So we should be trying to be collaborative and say, okay, this is what happens in the US, this is what happens in France, this is what happens in the UK, this is the culture in the UAE, in the GCC region. How can we make this most appropriate for this part of the world? But again, that will take time, it will take lobbying, it will take advocating. So yeah, this is why this, and venues like this are really, really important. So maybe at the next Palliative Care Conference, we'll have a ethics, legal issues masterclass. And so we have one more case to discuss. That's Dr. Rasha's case. All yours.
Okay, so my case now, to wrap up what we had over the last 2 days, at least to show that the collaborative work between, or the multidisciplinary work with, between physicians, community, and social groups, how much it can give impact in patient cares. So, yeah. Okay, so I'm presenting a case of a 36-year-old gentleman who was full of life and came to the country 9 years back looking for a job. He's the guy in the middle. And he came 9 years back looking for a job here, and he worked like as electrician or electric labor. And he was married just a couple of months before coming to the UAE. And he spent the first 5 years, it was very successful for him, doing his job perfectly and everything was normal, till the day he started to feel his abdominal pain and discomfort. He felt some also pelvic pain. He tried to ignore to the maximum, but it reached a point that he needed assessment and investigation. And at that point, he sought medical advice, and unfortunately, he was diagnosed with rectal cancer. It was a turning point for his life, and he started his treatment. It wasn't easy, definitely, going through surgery followed by chemotherapy and then radiation. During his radiation session, because he's a labor living in the labor campus, he has to walk all the way to the bus station, and then from there to ride the bus, and again another long walk to the radiotherapy in Al-Shahama Radiotherapy Hospital to have his session, and it's daily 35 fractions. This was a huge struggle for him, till one day he was waiting in the radiotherapy unit, waiting for his session. I think it was in the middle of his fractions. He met with this kind lady, and they start chatting. At that day, she was there to drop a friend for the radiotherapy, also a cancer patient for her radiotherapy. So she met him, and she started talking to him and asked him what's going on with him and why he's here. So she learned about his story, and she learned that he doesn't have enough support, and he needs someone to help him at least coming and going. From that day, she was devoted to not only her, she and her family, friends, and co-worker even. So basically, all of them, they were helping him going to the radiotherapy, chemotherapy, clinical appointment, not for 1 day or for 1 month, for over 2 years. Yeah. Okay. Not only this, as I told you, this is one day when she was helping him to going to his chemotherapy. She also was fighting for him, getting his visa renewed, because we all know, if an expat who's not working for a year, it's very hard for him to get his visa renewed, and the employer might not agree to continue. But she was there to fight for him, and she got his visa renewed. She managed to contact Red Crescent and Al Jalila, get his medicine, because unfortunately he started to be metastatic. And this medicine is very expensive. If we have oncologists over here, I think the box is over 20,000 per month. And she managed to get him these medications for 2 years. And the story continued till he declined, unfortunately, and his disease became advanced with extensive pelvic metastasis. At that point, we received a call from our colleague in Najda that they need our help to control his pain. He was just screaming of pain in the hospital, and they couldn't handle him. We accepted him, we got him in the floor, we started him with the infusion, and I remember hearing his scream from the corridor when I came to the floor. We tried our best with adding ketamine, combination with midazolam and everything, but the pain was still continuous, still very high doses. Remember one afternoon I called Dr. Murad, our colleague and consultant intervention anesthesiologist for a nerve block. And he asked me, Rasha, where to block? It's very advanced and extensive, but even though, because we need to do something. He was convinced, and he's very nice, an expert guy. He took him to the theater and he tried to block as maximum as he can, superior hypogastric, ganglion of Imbar, whatever he could. And surprisingly, it was very successful. The pain decreased by more than 70%, and it was an achievement for us. We were so happy with that. He's finally able to sit, eat, and this was the achievement. I thought that that day I did my part and I was so happy, but then this lady came to me again to make my life even more difficult, to tell me that she wanted to fulfill his last wish. This is, by the way, she was celebrating her birthday with him and us in the hospital. This is our team in the hospital, and this is Shija and her son Aman with our patient. She came and she told me he has been here for 9 years and he was just postponing this, and he was looking to see his family, and I want this to be happening. I didn't know how to do that because barely we managed to put him pain-free on the chair. We tried again to taper the IV medication, switch to oral, and when we told him that we will try, he pushed hard with us. And luckily, methadone kicked in, and we managed to switch all medication to orals. She was having her own battle now with his employer, getting his end of service, although he was not working for 4 years, but she managed to get it. She got him his end of service and ticket. And yes, this is him on the 22nd of December, 2023. We managed to repatriate him back to Bangladesh. I know I'm smiling, although it's a sad story, but this was successful for us, at least to fulfill the last wish for someone. He reached Bangladesh safely, and I'm so grateful, as I told Mr. Avtar, if he's still here, with the collaboration and help with Bangladesh, our colleague from Bangladesh Association of Palliative Care. They arranged medications for him and arranged the home visit, so everything was ready and they were prepared, and thank you so much for them, although they're not here, but our thanks to Sorgish and the team and Dr. Fazl. So everything was prepared in terms of medication, home care, and voluntarily and free. And he arrived home. This is his wife and mother. They were feeding him. I took a screenshot from a video. They sent us videos, many videos actually, of him. He spent the last days there with them. And yes, it was a success for us. And we felt really humbled and grateful for fulfilling a wish of a patient. And unfortunately, he passed away peacefully on the 1st of January, 2024. Thank you very much, and I just want Shija and Aman to come to the stage with me, please. The hero of my story, please. Thank you so much. Thank you for being here. Thank you, Aman, for everything. Thank you. And everything was done voluntarily. By the way, Shija is from India. It has nothing to do with nationality, with religion, but being a passionate, realizing that when someone needs help and being there to help was, I was so amazed with what she did. And I know that she's emotional, but she's ready to answer your questions. Yeah. Any question? I can see tears. Any questions?
Just thank you.
It was amazing. And thank you, Aman. Thank you so much. You know,
Could I-
I need to say something. And it was amazing. By the way, Aman is her only son. And when was that? 2023, beginning of 23. So our patient's name is Ghiyas. So Ghiyas said that he wants to see his wife is very young and he was newly married before coming here. He wants to see his family and he was wishing to do that, and he missed them so much. So she decided to send him there, but he was not in a shape to go alone. She was looking for anyone from her co-workers and her company, but they were not in a shape to go. She asked Aman, he's very young, don't look at him, he's just tall, but he's really young. He was 17 at that? He was 17. And
16 years.
16, and she decided to send him there. But because of the treatment schedule, they canceled. But I was so proud of both of them that he was willing to go alone, 16-year-old, to go to Bangladesh to support a patient reaching his family. So thank you again. Thank you so much. Yeah, you want to say something?
Say then, amazing, and what a human story. So my question to CJ is, why? Why did you feel you wanted to support him from day one?
Hi everybody. There was no such reason behind it actually. I went to drop, as she said, one of my co-dancers' mother wanted to go to the hospital, and I just was waiting for her radiations to finish in the lobby, so I met this gentleman. So when I asked, his plight was so hard, so he was in a camp in Musaffa. It is, the camp area, the laborers and all stays. So he used to walk for 10 minutes to the bus station, and from there he has to catch a bus for 35 minutes to Shahama. From there, again, it take a taxi for a minimum cost. If we go further to the hospital, to the cancer center, it will be more than minimum. So he get down on the minimum place and he walk again to the center. So when I asked, no one is there, I went with my friend, with her mother, with her daughter, myself in my car, in a very comfortable way. And this gentleman with a cover, plastic cover, and walking alone and in sweat and coming, I felt very, I don't know what to say that time. So then I asked him, next time when you want to come, please let me know. So this was for every day for my friend. But she was working in a company. Sometimes her company people or someone used to help him. But for him, no one was there to help. No one, and no money also, because he stopped working almost. So then I told him, I shared my number, and from 2020 or 2019 and till December 22nd, 2023, I was commuting whenever he needs. Sometimes I'm busy at my work. I used to send my drivers or my engineers, or someone used to pick him and do this. So many of the doctors, even when I go with him to the hospital, even the Rosewood Hospital, I say, who are you? So they look at me and look at him like, I also don't know what to say, friend or sister. Sometimes he says it's my sister. I say my friend, so it is contradictory sometimes. So I started saying I'm a global citizen helping one of my brother. That's all I used to say. And the journey continues, thankfully, even I'm into business, so we had very bad time in 2022 and all. One incident, barely having money in my hand as, cash. So I used to go and meet him during this COVID time to the camp. So everyone used to tell me, Shija, don't go, it is a camp, you will get COVID. But, he also used to come with me. And that day, literally, I was not having any personal money with me. Only the company money, some money is there, which I need to use for the next week. So I just gave a 500 dirham and gave to him. And then I was feeling wrong, inside. Did I do the right thing or not? Because that much, then I was, that time Aman was not with me, I was alone, yeah. I got inside the car and I was crying, God let me know whether I did right or wrong. Should I look into my family or this? Then suddenly my husband called, he never used to call like that, but he said, when I said this, he said, you did the right thing. Now he need that money. You need that is after 1 week for your contractors or somebody. So you did the right thing. Like that, many, feelings like, so he asked me, like many people ask here also, why me? And when he's sitting in the car, he used to talk to me a lot. So once he asked me, ma'am, why to leave? I am dying. My wife, what she will do? So I didn't have any answer, So the tip of the tongue, it came to me that I said, my dear, you at least know that you are going to die. I don't know when I am going to die, because I'm driving every day and I don't know whether I'm coming back or not. So God loves you more. So he informed you earlier, so you can do things. So he told me many things, what he wanted to do. Everything I was trying to fulfill. Because earlier I used to tell him to go home and visit and come. He never go. He never wanted to go. He wanted the treatment. And in 2023, he wanted to go, early 2023 or 2022, and early 2023. Then I was not able to accompany him. He's a man. Somebody has to, I can send him, but someone has to assist. Then Amman told, okay, Amma, I will go with him, because he was physically a little bit big also even that time. So I said, okay, at least he can hold him. As a lady, I'm hesitated to go. So then, I could do those things for him. And he wanted to eat, some Bangladeshi food. And sometimes he's so depressed, then the nurses, when I talk to them, they call me. Then, when I go there, he used to eat food. Then one day I told, even that video I sent to her, one day I told, see, Ziaz, if you are like this, Dr. Neil will be very sad. You are so depressed, you are not eating anything. Then you talk to Dr. Neil. For 5 days, he was not talking anything. He was not eating properly. That day he was eating, and he sent a message to Dr. Neil. Dr. Neil, how are you? When are you coming to the ward? Like that, the video is with her. So, what else? Please ask me.
Thank you. Amazing.
Yeah. And on the top of that, I really wanted to say that it's all happened, especially in this part of the world. When I went to the Bujil Medical Center, Dr. Neil and Dr. Rasha was very supportive. Otherwise, as a unknown person who is not a relative or friend, it's not possible to do like this. But they really support. Shija, okay, you sit there. In any time, I could walk into his room and I could sit with him, because I told you I'm also working. So whenever if I go to that area, I'll just peep into. So that was possible only because of, even I fought with their departments also sometimes for the radiation department or some, but still, they were very supportive. I feel, I don't know how to thank you, Dr. Neil and Dr. Rasha. They were amazing humans. I don't feel they are doctors they are just angels.
Thank you.
Really. Sir, please.
Actually, we don't know how to thank you. You are the angel, you are the hero, actually. No words. Such a human behavior. Hopefully, all of us, we have at least 10% on what you have and what you said for them.
Yeah,
my question.
Yeah.
Do you have engaged in any NGOs so as to deliver all of this
No.
human behavior to others? And my second question, what's your message to the community to be engaged in such work? I think we need this in the palliative care. Thank you.
First question, I'm not enrolled in any of the NGOs. I tried with the Red Crescent so many times, but a lot of formalities and somehow it didn't work. Years before that happened actually. But during this time, I was forced to approach them for the food and medicines, and because every month he needed almost 27,000 dirhams medicine, special medicine something. So this was impossible for me to provide. So Al Jalila Foundation and the Red Crescent had helped a lot with Axios. That was the agents, I think. So we applied and happened. But personally, I wanted to do things like that. But there is, of course, if I inquire more, go after, I might find out. But unfortunately, whenever I search for, I couldn't find this solution for that. So I was asking a couple of the members from here how to get into that, especially Mr. Avtar and ma'am, Dr. What's her name? Yeah, 5, yeah. So I was asking people like that. So if any chance I'm ready, I can volunteer. Of course, I wanted even children also to come to know that how hard the life is. And Aman, surprisingly, he was okay with coming with me, driving for him. And because I thought maybe the young children of this age, they don't like to sit with the patients and go to the hospitals and all. But he was ready. So it was a great support for me. Otherwise, if they are, both husband and he is not allowing me, it would have been, I will be in trouble actually. So the second question, what was that? Come again, sir, sorry.
The second question?
Message to the community. Actually, community, they are ready. We are not getting opportunity or the correct platform actually, especially in this part of the world. So what I'm saying is, if to the community, I'm no one. I'm just thinking I was an instrument for him to help from the God, because he was a very God-fearing boy. 5 times Muslim prayer. I am from a Christian community, but he used to pray 5 times. So I believe that it is God's intervention. God sent me as a messenger to him. But I want to do more. Now I am 50 plus, so, let my children grown up, so I wanted to do more. So to the community, what I say, if you get a small chance, even somebody is sitting there and, to give a hand to get up, and to sometimes only just to give a hug, it can make a lot of changes in their life. One more thing I'll tell you. One day, one of my colleagues, 10 years before, 2009, not 10, sorry, 2011, she came down to my building. I just coming out of this shop, and I met her there. I said, how come you are here? What, you came to the Lulu? She said, no, Shija, I wanted to meet you. That time, she's a colleague. She's not my friend, close friend or something. She said, I want to talk to you. Come to my house. It is 40 to come anytime. She said, oh, no, I'm getting late. I have to prepare food for my husband. I'll talk to you later. So I told her, she's a small-built girl. So just I shook her on the shoulder, just shook her like that, and I said, you come anytime, my room will be open, even my family is with me, my young child is with me, don't worry. You come anytime, even at night also you come, we will talk, not a problem. Now you go and prepare food for your husband. Second day I met her, I didn't ask anything, she also didn't say anything. Third day also same, it goes on, and I didn't ask anything. After 7 months, she came and told me, oh, now she told me, Shija, if I wouldn't have talked to you that day, I would have suicided. Oh my God, I don't know who made me to hold her and shook her. shoulders, and because I'm a big person, she's very small, the shook it was really hard. So it felt, she felt that, I think it's from there. So to the community, what I'm saying, see, that time I never knew that this is going to work out, it is going to make any change in her life. And same like in Zia's case also, I was not expecting anything like this and all something. I just wonder, I sit with him, I talk to him, when I met him in 2019, the doctor told 9 to 1 year life for him, but he lived until 2024. And I believe that it's because of me. Sorry, Dr. Neil. Yeah.
I think I need to hear the same message from Aman also. What is, especially you are very young, to your generation and to the community. Can you give a message?
My message, hi everyone. My message would be to not hold back. I'm not that experienced in medicine or in any terms of psychology or whatever, but every time I see like a cafeteria worker or, it could be the most normal person ever just walking by you. They get treated so harshly, they could be have things going through your head, whatever. I'm proud to say this, to this day, I've never disrespected a worker because I would imagine myself in their shoes. The other day, this is so normal, I just went to the KFC and the guy just looked like he was mad, he was just fully pissed, but then I went to him and I was like, how are you? I shook his shoulder, I held his hand, I was like, how are you today? See, this is like a fat thing to say because I used to eat KFC a lot of the time, so he knows me. So I'd just be like, how are you, a long time, innit? Because I was on a diet and then I went back, I fell off the diet. So I was like, well, go on, how are you? Just shook his shoulder, whatever. And then he was so happy to just see me. He was having the worst day of his life. He just so happy to see me. I ate KFC with him. He's the guy who cleans the table. But the fact that he had someone recognize him, talk to him, appreciate him for what he does, changes a lot. And that's the only thing I tell people every day. Don't hold back. Don't think about what other people think. If you can help them, help them. If you can't help them, get someone else to help them. You're not going to lose anything. Sure, money goes and money comes back. A life, once it goes, you can't get it back. Thank you.
You think that you can provide any service or any help to patients, young children or adolescents, teens, this difficult age, especially this difficult age group, do you think you can support them by any means?
Yeah, I most definitely think I can help because I'm really good with kids. I love kids, right? And I'm usually a good person that people take advice from me. I've told a lot of people about the experience with GIAS. I've led a lot of people into having some more confidence in going up and helping people out. I have friends that do a monthly giveaway of food in labor sites. Small things. I'm not a millionaire. I just have like a little bit of money that I save up, get some food for some of the construction workers beside my house. Probably have a nice chat with them. I don't mind losing 30 minutes of my life. What am I going to do? Play games? No, I just talk to the guy. He's happy, he's smiling, and then that makes my day, that makes his week, that makes another person's month, makes another person's life. So I'm quite sure my generation, if they say they can't, it's just an excuse. Anything is possible. Yeah.
Yeah, it's not a question, just to say thank you to you guys for allowing us to care for GIAS. Thank you for trusting us. And it really is quite emotional. I think, Aman, you're amazing for coming in at such a young age. And I remember you knew a lot about GIAS's medical history, the information that you shared. And it's really important that we plant the seed of palliative care in young adults from a very young age so that they can take that forward. And I won't ever forget what we've achieved together. And I just want to thank you on behalf of the palliative care team. And Shuja, there's no words to express, but thank you so much for allowing us to care for him and having those special moments like celebrating your birthday with him. Very, very special moments.
Thank you. Thank you so much. Thank you so much.
Thank you, everyone. Any comment? Any question?
I think it's a beautiful story to end the conference on.
Yes.
It's true human spirit. Thank you so much.
Thank you.
Okay. Okay, I don't think there's anything left for me to say. I think this is a true example of compassionate community in action. It's 5 to 4. We finished an hour early, something like that. Almost an hour. Yeah. Okay. Should we do that afterwards? I'll just say 2 words. So I think this is the last few minutes of the conference. I'd just like to say thank you very much to everybody for your support, for your enthusiasm, for lasting till Sunday evening. Thank you so much, and we look forward to doing this again next year. We'll plan it a little bit better, and next year we'll get a tissue company to do some sponsoring. Thank you so much. Thank you. See you next year.
The background.